Hello, everyone. Welcome to our presentation of the prostate cancer study-a-thon we had in March this year. My name is Kees van Bochove. I'm the founder of The Hive, and with me is also Asieh Golozar from Regeneron. However, we are presenting this on behalf of a huge team that's coming from different projects and communities. So the main supporting project for this study-a-thon is the Pioneer project that focuses on building a big data platform to research prostate cancer. Then there's also the EHDEN project, which you might be familiar with. Works very closely with the OHDSI community, and it focuses on building a network of OMOP data sources throughout Europe and using that to generate evidence. And then, of course, you know the OHDSI community. Asieh, do you want to take us through some of the findings from the study-a-thon that we have so far?
Sure, thank you, Kees. So when a patient is diagnosed with prostate cancer, there's a critical decision to make, to treat or not to treat, and then when and with what intensity. Committed decision is to let's start a treatment right away. We call it immediate treatment. Or no, let's wait. We're gonna manage these folks conservatively. Either follow them up intensely and only start treatment when a tumor shows aggressive behavior. This is called active surveillance. Or no, let's just follow them up and only start treatment when symptoms occur. This is called watchful waiting. So for the rest of the talk, I'm going to focus on conservative management as one bucket. The idea was first introduced in the 1970s. First watchful waiting and then active surveillance, and we're seeing an increase in the uptake of this approach over the years. But at the same time, there is variability of uptake across practices and geography. Generally sounds like a great idea, right? Avoid over-treatment, reduce treatment-related burden. But where is the evidence? What do we know about it? In general, there's lack of information on the long-term outcomes of these patients. And also, we don't really know the impact of individual patients' characteristics and baseline comorbidities on the outcomes. Also, there hasn't been any systematic approach for an accurate determination of patients who are most likely to benefit from this treatment strategy at the point of care. And all of these were the impetus of the study-a-thon that Kees just mentioned, with the objectives that you can see on the screen. The first one was to investigate the natural history and outcomes of prostate cancer patients under conservative management. As with any study, we started with defining our patient population or our cohorts. We got input from the experts, looked into the literature, consulted the data to identify the cohorts, more specifically to be able to distinguish immediate treatment from conservative management. And for this, we used the 6-month cutoff to define these two patient populations. We did a large-scale characterization study looking at 21 target cohorts, 43 subgroups, 40 features in 4 different time windows, a total of 140,000 summary statistics per database. We had 18 different data partners from US and EU, as you can see on this screen. Different types of data: academic EHR, community-based EHR, nationwide claims, and cancer registry. And we have results. You can go here, explore, go through the results. Also, there are links to the protocol, analytics codes, and the diagnostics results. Let's take a look, sneak peek. In total, from 12 databases so far, we've been able to identify 1.6 million incident prostate cancer patients. Majority of them, 900,000, were managed immediately under immediate treatment, meaning that they got treatment within 6 months after diagnosis, and the rest, 500,000, conservative management. Looking at the age structure, we see that the majority of cases are older, 65 to 80, as we expect with prostate cancer. A little bit of a difference across databases. Comorbidities pretty much similar between conservative management and immediate treatment. But the question is that does the choice of cutoff matters? If we're looking at different cutoffs, but to decide and define conservative management, are we seeing something different? Looking at here, see that the answer is no. Again, looking at baseline conditions prior to index across cohorts between the two treatment groups, we're seeing pretty much similar distribution, only a slightly higher proportion of genitourinary condition immediate treatment group. And finally, we looked into the outcomes. What you see here are the frequency of selected outcomes within a year after index date. We can see higher proportion of treatment initiation and hospitalization in the conservative management group, but pretty similar rates of symptomatic progression in both cohorts. Okay, what have we learned so far? So in general, we saw no difference in comorbidities and age between the two treatment groups, implying that the choice of treatment, the treatment decision is likely to be based on some other factors, maybe tumor stage or grade. We observed low rates of hospitalization and treatment during the follow-up of these patients, less than 20%. It's kind of implying and highlighting the fact that there is a benefit to this initial treatment decision-making that did not actually cause harm. The question is, can we improve this treatment choice and decrease the occurrence of outcome from just 20% to say 5 or maybe 0? And that is actually task of an ongoing prediction study looking into this question. So I just showed you a little bit of what we found. There's a lot of data, a lot of results to go through, and I want to use this opportunity to invite you all to come and join us, and let's generate some meaningful evidence for prostate cancer. Contact us if you have any questions. Thank you so much.